We are live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Scopy in OG, organized by TNFOG. So it's my privilege to introduce the MOC of today's webinar, Dr. Gayatri ma'am. Ma'am is currently the consultant at Shamla Nursing Home, Trichy, and also executive member of Triox. I welcome you, ma'am. And it's my privilege to introduce Dr. Radhika Gauri, ma'am. Ma'am is the consultant in BG and clinical lead in ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you, ma'am.
Sahiti, please enable my video. Good evening, ma'am.
Good evening.
Good evening, Sampath ma'am. Good evening, ma'am.
Good evening.
So this is the next interesting session of TNFOG, and let's start the session with a prayer.
Gayatri can start. Gayatri and Radhika, over it. Sahiti, are you there?
Is audio visible? Is audio there, ma'am?
Yeah.
Okay.
Lamp lighting. So I thank the organizers, Dr. Vidya Prabhakar ma'am, who is the president of TNFOG, and she is the clinical director, chief consultant of Obs and Gynae Infertility Conceived Couple Care Clinic in Salem, and senior IVF consultant Birla ARMC IVF Salem, and she was a vice president of TNFOG until last year. So her special interests are in high risk pregnancy and infertility. Welcome you, ma'am. And I invite Dr. Sampath ma'am, who is the host and organizer of this program. She's a professor.
It's enough. I will do the
Okay.
Yes, good evening to all. I welcome you all for the TNFOG Marathon CME. I welcome Dr. Madhuri Patel, Dr. Alka Pandey has not joined. I think Dr. Ragini Agarwal.
Yes, I joined.
Madam,
yes,
I
joined.
Ragini Agarwal, I told her before a month itself. I welcome all of them for the chief guest and the guest of honor. This is the Marathon CME, which is conducted every month on the second Friday. We have a theme. Today's theme is Scopy. We have 3 sessions. First session being the Yuva, and the best Yuva will be honored as Yuva orator in our annual conference. And the second session being the update, and third being the panel. All will be on the same theme. So I really thank Dr. Madhuri Patel, Dr. Ragini Agarwal, and Dr. Alka Pandey for accepting this, and our Sumanna Manohar madam, who has accepted to give the update, and the panel by Dr. Meena and Meenakshi and the Yuva. So we will go with the scientific section. Now I'll welcome our president, Dr. Vidya Prabhakar, to introduce the chief guest and the guest of honor. Okay. Vidya madam.
Madam Vidya Madam not available, ma'am. Today.
Not here,
Okay,
ma'am.
then Dr. Ramani Devi will introduce. Madhuri Madam has not yet joined. First, you can introduce Dr. Ragini Madam and Alka Pandey Madam, or whatever is. Alka Pandey Madam is there. Ramani Madam, would you like to introduce?
I think ma'am's going for an off appointment, ma'am.
Yes, Dr. Alka Pandey. I myself, I welcome Dr. Alka
Welcome,
Pandey.
ma'am.
She is the vice president and one my best friend. And we both were the vice president during Dr. Rishikesh Pai's time. And she is the ICOG governing council member and national corresponding editor. And she was the president of Patna Society, chairperson of Practical Obstetric Committee. And she has many awards and she has done many government programs. Dr. Alka, we need the blessings of you for our the success of our webinar. Dr. Alka Pandey.
Thank you so much, Sanpat. Thank you so much. You gave me the
Welcome.
opportunity. I'm really very thankful to you. Thank you so much. And Dr. Vidya and the other team members, I'm very grateful to you that you have given me the opportunity. And Sampath is a darling of mine. And she is very hardworking. And she has done many works in adolescent health. And I wish all the success to this marathon CME, and let us begin it.
Thank you, Dr. Alka.
So
Thank you.
one thing more, if there are participants here, I would like to request you all, because I'm going for the post of Foxy representative to AOFOG, kindly do support and vote for me with folded hands. I request you all.
Yes,
Okay.
Alka is going for our AOFOG representative from Foxy. All the best, Dr. Alka. Then we
Thank you.
have our Dr. Ragini Agarwal. Can I have the CV of Dr. Ragini Madam? Dr. Ragini Madam now conducted the managing council meeting. Fantastic. So Ragini Madam was the vice president of Foxy and the founder president of the Association of Obstetrics and Gynecology of Haryana and fellow of clinical gynec endoscopy, aesthetic, functional and regenerative gynecologist, female sexual health specialist and director AA Dharma Science Complete Clinic for Women Health Gurgaon. In Haryana, whatever it is, whether it is a Menopause Society or ISOPAB or IAG, the founder will be Dr. Ragini Madam. If Ragini Madam is telling, everyone will listen to her. And she was the best committee chairperson in DMS IMS 2022, IMS President Appreciation Award 2022, CL Javari ICOG Symposium Award 2024, IMA National President 2021 Appreciation Award, IMA State President Award, National President IMA Appreciation Award, many awards to Dr. Ragini Madam. Dr. Ragini Madam, we welcome you to the TNFOG Marathon CME and we need the blessings of you. Dr. Ragini, stage is yours.
Thank you so much, Dr. Sampath, for this opportunity to come again virtually to Tamil Nadu. Tamil Nadu is such a special place in my heart. Ramni is there. Me and Ramni, we are VP together under Dr. Alpesh. And
Yes.
Tamil Nadu is such a special place. My only son has done medical graduation from Chennai.
Oh,
So,
fantastic. Yes.
So, and I can only wish you very best for your future endeavor. And the topic chosen today is so important because I still remember the days of 91, 92 when laparoscopy was started. And Dr. Kudsem, who is considered a modern father of the modern laparoscopy, he was even put in an asylum. That man is mad. He wants to do surgery by a hole. And today, if you cannot do a surgery by a hole, you are not a surgeon. So things have always a 360 degree, and it is very essential to each and every gynecologist, specifically the newer gynecologist should know laparoscopy. It's a very good thing that you have a theme CME, and I think everybody is there to listen eagerly to all of the experts. Again, thank you so much for giving me this opportunity.
Thank you, Dr. Ragini madam. Thank you for the nice words. Okay. Radhika, when Madhuri madam is joining, we can involve her. We can go with the scientific session. Dr. Ragini, we will call you in person. Now we have called you in a webinar. We will call you in person to Chennai during my tenure.
And what about me, ma'am?
Alka Pandey, you are already there. I have already told you that you are coming in October.
Yes. Yes.
Definitely. Okay. We will go with the scientific session. Dr. Gayatri, you can introduce the chairperson for the Yuva session. Dr. Radhika? There is some net problem, I think. I'll introduce the chairperson. Dr. Shanti. Dr. Shanti is the professor in Savita Medical College, and she is our continuous judge for the Yuva speakers. And the next person is Dr. Kartika Prabhu. Kartika, are you there?
Yes, ma'am, I'm there.
Yes, Dr. Kartika Prabhu is the professor from SRM Medical College. Both of them are good teachers and they have the teaching experience of more than 15 years. And they are the constant judge throughout the year to judge the Yuvas. And the best orator, as I told earlier, will be awarded in our annual conference. Dr. Shanti or Dr. Kartika, you can introduce the first speaker. For the speakers, the time is 12 minutes, 3 minutes. The judge will ask you questions.
So our first speaker is Dr. Belinda Frank. She is currently doing fellowship in endogynecology in Sudha Sundar Hospital, Nagarkoil. Her field of interest is in gynec endoscopy and infertility. She will be giving a talk on basics in hysteroscopy.
Share Pandriyama.
Dr. Belinda?
Yes, ma'am. I'll share the screen, ma'am. Ma'am, is it visible, ma'am?
Yeah,
To
your
slideshow,
email
ma'am.
thing is...
Go to slideshow.
Yes, ma'am. Can I start, ma'am?
Yes. Slideshow is not there. Oh, yeah, you can start.
Yes, you can start.
Good evening, ma'am. Today we'll be discussing about the basis of hysteroscopy. Pantalone in 1869 used a tube with external light source to diagnose a polypoidal growth in a 60-year-old with postmenopausal bleeding. And Rubin in 1925 used hysterourethoscope to look into uterus, and he first used carbon dioxide as the distension media. In the early 1990s, the present hysteroscopic surgical procedures became popular. Hysteroscopy is derived from the Greek word hystra, meaning uterus, and scopia, to view. Hysteroscopy is a procedure to view the inside of the uterine cavity with a telescope-like device called as the hysteroscope. It is a diagnostic technique. It allows direct visualization and accurate localization of the intrauterine pathology for sampling purposes, and it is more sensitive in detecting uterine pathologies when compared to transvaginal ultrasound and hysterosalpingography. The contraindication for hysteroscopy procedure are pregnancy, heavy uterine bleeding as it causes poor visualization, cervical or endometrial malignancy because of the risk of malignant spread into the peritoneal cavity, acute pelvic or vaginal infection, and any recent uterine perforation. The indications for hysteroscopy procedure are abnormal uterine bleeding, postmenopausal bleeding, abnormal hysterosalpingography or ultrasound, in cases of unexplained infertility and prior to ART, congenital uterine malformation, any suspected intrauterine pathology, recurrent pregnancy loss evaluation, and in presence of intrauterine foreign bodies like neglected IUCDs. So these are the equipments used in the procedure of hysteroscopy. It is broadly classified into optics like hysteroscope and the resectoscope. The commonly used hand instruments are scissors, grasper, and biopsy forceps. Hystofluoride is a carbon dioxide insufflation media which was used in the older days. Endomat or hystropump is used for media delivery system. The endovision system consists of the camera, light source, light cable, and the monitor, and the electrosurgical system. So first is the rigid hysteroscope. The telescope has three parts: eyepiece, barrel, and the objective lens. It is based on the rod lens system. The 4 scope has a sharper and clearer view, and the viewing angle ranges from 0 to 70 degree. The most commonly used ones are 0 degree for the panoramic view and 30 degree 4-oblique view provides a better visualization of the tubal ostia. Betoki 2.9 mm hysteroscope is being increasingly used in the recent times, and it can be used as both panoramic and micro contact hysteroscope. In contrast to it is the flexible histoscope, which is used for office histoscopy. It's a 4 to 8 mm fiber optic histoscope with a soft flexible front portion, rigid rotating middle portion, and a semi-rigid rear section, and it stiff deflects over a range of 90 to 120 degree. The camera consists of the camera head, cable, and the camera control. The endoscopic microchip camera coupled directly to the telescope with the digital recorder. The focal length of the camera lens ranges from 25 to 38 mm, and 28 to 30 mm is commonly used and provides a better vision. Light generators, the quality of which depends upon the wattage, which is 175 watt is used for routine procedures and 300 watts for operative procedures. And remote light generators available are halogen, xenon, and LED. LED is used nowadays and it provides a better illumination. And finally, it depends on the structural integrity of the fiber optic light cable. There are two different types of sheath available, which is a diagnostic and an operative sheath. Diagnostic sheath is used to deliver the distinction media into the uterine cavity. For a 4 mm scope, it is ideal to use a sheath of 5 mm, and the 1 cm difference is for the clearance of the distinction media. Imprecise or loose coupling of the telescope and the sheath will result in the leakage of the media. The diagnostic sheath can be both single and double channel sheath are available. Next is the operative sheath, which is 7 to 10 mm in diameter, and it has channels for telescope, installation of the media, and for the introduction of operating instruments, which can be semi-rigid or flexible instruments. And the size of it is 7 French, that is 2 to 3 mm. It can be of two types based on the number of inflow channel. The standard operating sheath has a single inflow channel, whereas the isolated multiple channel sheath has a double flushing sheath, which allows media installation by the inner sheath and the return by the perforated outer sheath. This is an image showing the histoscope with its hand instrument and a single and multi-channel sheath. Next is receptoscope. The receptoscope with its inbuilt wire loop or other devices uses high frequency electric energy, which may be monopolar or bipolar, to cut and coagulate the tissue. While using monopolar energy sources, hypotonic, non-conducting, non-electrolyte distension media like lysine, orbital, or mannitol can be used. And while using bipolar energy sources, isotonic conducting media like saline and linker lactate are used. The parts of the receptoscope or histoscope, which ranges from 2 to 4 mm with a 30-degree weaving angle, working element, inner and outer sheath, obturated, and the electrodes are knife, loop, or a ball. This is an image showing the receptoscope with these different types of electrodes. The next is histoscopic modulator. In contrast to receptoscope, which uses electrical energy, modulator uses mechanical energy, which is suction-based rotating tubular cutting system to resect the uterine tissue. It uses saline as the distension media, and the different types of modulator available are True Clear, Myosure, and Bugatti. This is Endoc, which is a handheld portable flexible histoscope, which is used in office histoscopy. It is also provided with an operative channel for introduction of operative procedures. Sterilization of the instruments. The standard method is gas sterilization with ethylene oxide, but the most commonly used method is Cidex with 0.55% orthothalate. In this, the instruments are soaked for 12 minutes at 20 degrees Celsius, followed by 5 minutes at 25 degrees Celsius in an automatic endoscopic reprocessor. Then it is allowed to rinse for 30 minutes to completely remove the residual solution before introduction of the instruments into the cavity. Now we'll be discussing about the distension media and the fluid management. The minimum pressure used to distend the uterine cavity is 40 mm mercury, and whereas the pressure to propel the media through the osteo is 70 mm mercury, and it is the most ideal pressure used in day-to-day practice. When there is case of uterine bleeding, the pressure can be increased up to 125 to 150 mm for better visualization. Any media should be pre-warmed to room temperature to avoid the risk of hypothermia. There are three different types of media delivery system, which are gravity flow, in which the media is allowed to stand at a height of 6 to 8 feet above the table. The second is the pressure cuff, which is pressure gauge. And third one is rotary pump or hystromat, which is the ideal and preferred method as it provides the real-time fluid deficit. An ideal distension media should be isotonic, hypoallergic, non-hemolytic, non-conductive, ease of instrument cleaning, and should have minimal impact on the body and the fluid volumes. The types of distension media are broadly classified into gaseous media like carbon dioxide and liquid media, which is further divided into low viscosity media and high viscosity media. Both gaseous media and high viscosity media are not generally in practice. The low viscosity media are subclassified into electrolyte-rich media like NS and renal lactate and electrolyte-poor media like mannitol, sorbitol, and glycine. This is a chart showing the advantages and disadvantages of various distension media being used. As we all know, the hypertonic media and isotonic media are commonly in practice. The isotonic media like NaCl and renal lactate is used with diagnostic and operating hysteroscopy, where both bipolar energy and mechanical energy are used. It has also the risk of pulmonary edema and congestive heart failure, but its risk is minimal than the hypotonic media. Whereas the hypotonic media is used in monopolar devices and it has the disadvantage of excessive absorption leading to the TRP symptom like hyponatremia, hyperammonemia, decreased osmolarity, and cerebral edema. Hiscon is being rarely used because of its fluid overload, bleeding diathesis, and anaphylaxis. This is a combination of the clinical uses of different distension media. The important part of fluid management is fluid and electrolyte monitoring, especially while using hypotonic media like sorbitol and glycine. When the fluid deficit reaches a level of some 50 ml while using hypotonic media, the electrolytes level should be sent immediately and the procedure should be terminated at 750 ml in case of old age and with people with comorbidities. And in young healthy individuals, the procedure should be terminated when the fluid deficit is about 1 liter. Whereas while using isotonic media, when the deficit allowed for termination for healthy young individuals is 2.5 liter and for old age and with comorbidity is 1 liter. So next is a patient preparation. The hysteroscopy is usually done in the follicular phase of the menstrual cycle. No prophylactic antibiotic is recommended and no routine cervical dilatation is being done. Cervical dilatation can be required only in cases of cicatrized or severely stenosed cervix and it can be done with intravaginal misoprostol or by injection of dilute vasopressin into the cervical stroma, but it is mostly not being practiced. Now we'll be discussing about the diagnostic hysteroscopy. Diagnostic hysteroscopy is usually done under IVGA in an OT setup or in an office setting with local anesthesia. It is used to evaluate cervical as well as uterine factors. Whereas in contrast, office hysteroscopy is a procedure without anesthesia and short simple procedure with 30 minutes or less are usually selected. It uses saline as the distension medium and smaller diameter probes are being used. Vaginoscopic no-touch approach causing distension using saline is being used in this method and it can be combined with the CN treat approach where therapeutic procedures can be merged in the same setting. This is a video showing the procedure of diagnostic vaginohysteroscopy in which a patient is placed in the lithotomy position and after gently separating the labia, the hysteroscope is introduced into the vaginal introitus and the vaginal wall should be inspected. After visualizing the external os, the hysteroscope is introduced into the endocervical canal and look for any pathologies. And through the internal os, the hysteroscope is introduced into the uterine cavity and a systematic examination of the fundus of the uterus followed by bilateral tubal ostia should be visualized and the anterior and the posterior wall should be inspected before taking the hysteroscope out. These are some of the common abnormal findings seen in diagnostic hysteroscopy. In cases of chronic endometritis, we could see micropolyps, strawberry appearance, and hemorrhagic spots. In cases of adenomyosis, we can see focal defect in the ectopic endometrium, hypervascularity, submucosal hemorrhagic cysts. And these are the images of hysteroscopic findings in endometrial polyps. And in case of fibroids, we could visualize type 0, which is completely pedungulated intracavitary fibroid, and type 0, which is a sessile fibroid with less than 50% intramural component, and type 2, which is more than 50% intramural component.
Sorry to interrupt. 1 minute more, Dr. Belinda.
Okay, ma'am.
Kindly finish.
Operative hysteroscopy is inserted into the operative or resectoscopy sheath. Careful dilatation of cervix prior to negotiation should be done. The cavity is scanned and pathology should be localized prior to the introduction of the operative instruments. Operative procedures can be performed simultaneously with laparoscopy to avoid the risk of perforation. These are the indications of operative hysteroscopy, as we already mentioned. The complications of hysteroscopy are extremely rare and in diagnostic hysteroscopy accounts for 0.13%, where operative hysteroscopy, the complications occur in 0.95%. And the most common complication occurs with the hydroxylysis procedure, it's 4.48%. The most common complication is uterine perforation, which is 1% and 54% occurs at the level of entry. Perforation occurs with forceful dilatation at the entry level, and it also mostly occurs with laser or electrosurgical devices. And this can be reduced by activating the electrode only in its return phase. Perforation is highest with septal resection at the level of fundus, and the sign of perforation is sudden loss of distension. And once it is identified, the procedure should be terminated and proceeded with laparoscopy or laparotomy. Next is the fluid overload. Any fluid can cause fluid overload when it is excessively administered. It happens when the intrauterine pressure exceeds the mean arterial pressure. There's a chance of extravasation into the venous channel, and the factors contributing to it are uterine TB, submucosal myoma, recent traumatized cavity, or infection. The factors contributing to the fluid overload are hydrostatic pressure of the insufflation media, increased exposure to the blood vessels during ablation or myoma resection, prolonged duration of procedure, and women with fertile age group are high risk of hyponatremic encephalopathy due to the inbuilt estrogen level. And when the deficit is more than the allowed limit, the sodium level should be checked immediately and after 4 hours of the procedure, and it is managed with diuretics like furosemide. Gas and air emboli. Gas embolism occurs with
Belinda, you are exceeding your time.
Ma'am, only 2 more slides, ma'am. Gas embolism occurs when histoscopy is performed using carbon dioxide distension media, or when laparoscopic carbon dioxide insufflator is connected to the histoscope. Air embolism occurs as a result of introduction of ambient air into the cavity and by repeated passage of scope or by creation of vapors during electrosurgery. It is recognized by the fall in EtCO2 and Melville number, and it is prevented by avoiding the Trendelenburg position, which produces a negative pressure in the pelvic veins, promoting air and gas entry into the venous circulation. And once it is identified, the patient has to be put in Duran's position, which is a leg lateral decubitus and Trendelenburg position, to prevent air entry from the right ventricular outflow tract into the lungs. This is a outflow of the complication of histoscopy. And the last slide is the post-histoscopy instruction to the patient or cramping is common, which can be treated with NSAIDs. Frequent urination may occur for 24 hours after the procedure. Bleeding may occur for a few days after the procedure, and it is advised to avoid sexual activity for a week after the procedure just to avoid the risk of infections. Thank you.
Good presentation, Belinda. You have
Thank you.
explained everything in detail. So you told about fluid overload. How can you
Yes.
prevent fluid overload during histoscopy?
We have to keep a check on the inflow and the outflow level. Ma'am, this can be monitored by keeping the urological pouch or drape hug below the buttock of the patient, which gives a level of the outflow. And by using histomat, which is a mechanical device which gives us the level of the inflow and the outflow, can be monitored.
How else you can do?
Uh,
Suppose you are having a big fibroid for histoscopic myomectomy, what you can do?
We can make the procedure in 2 settings, madam.
Yes. So you should not prolong the surgery. So you have to make it as 2 sittings.
Yeah. Okay. A very good presentation. Yes, we can move on to the next session, right? Yeah, that's good.
Karthika, you can introduce the second speaker, I think. Radhika, speaker irukangla?
Yes, ma'am, I'm here.
Yes, okay.
Introduction slide is
Ma Sahiti CV podu.
Sahiti.
Yes. Sahiti? 1 second.
Karthika, introduce as a Yuva speaker and her topic.
She's consultant Kaveri.
Dr. Siraj Fatima. She's a consultant in ARC Infertility Center, and she's currently consultant in Kaveri Hospital also. Field of interest is high-risk obstetrics and laparoscopy. She'll be giving a talk on basics in laparoscopy.
Yes.
Please stick on to the time.
Yes, ma'am.
Yes, Dr. Siraj, you can start presenting.
So, can you see the slides, ma'am?
Yes.
Yes.
Yeah. Very good evening to one and all. Thank you. I thank TNFOG team for giving me this opportunity. So today my topic is basics in laparoscopy. It's a very huge topic to be covered in 10-15 minutes. I'm just going to give you a bird's eye view of the things that are happening through the OT and what are the instruments used, trolleys used. I'm just going to discuss for that. So going to the history, the first laparoscopic procedure was done on dogs in 1902. In humans, it was done by Hans Christian in 1910. So under operating room and in sterile conditions, 1980, it was done by Patrick Steptoe. And the first camera video recording laparoscopy was done in 1982. And the first lapistectomy was done in 1989 by Reach et al. First I'll start up with the operating room, laparoscopic operating room requisites. The operating room should be very spacious to occupy the trolleys, and the tables should be of flexible and moving type. And the walls of the laparoscope should be seamless, made up of galvanized steel, so that it can be cleaned easily. And the laparoscopic room should have movable pendant lights and adequate monitors for the assistant and the surgeon to see seamlessly. So the laparoscopic tower, this is the basic trolley used in laparoscopy. We all should be aware of these things. This is the monitor, this is the light source and the camera control unit. This is the insufflator used for gas insufflation and the suction irrigation system. And this is the diathermy trolley, the roller stand, and this is the video recorder. I'll describe in detail in each one of these things. So first is the camera. So this is the camera head. We call it camera head used in laparoscopy. This is the couple charge device, CCD we call, and this is the coupler. This camera head has a three chip system, which includes the red, green, and blue light. It is of 1080 pixels resolution. It consists of a gold lens and a prism assembly. And this is the light source, which contains the fiber optic cable. And this cable should not be folded. It should be in a round way. If you bend or the fold, I think these fiber optical cables may break and the light source may not work. So the light source commonly used the halogen was used in olden days. Now we commonly use the xenon and the LED cold lights. The xenon consists of the compressed xenon gas inside the xenon lamp. The advantage and disadvantages are the LED cold lights are long, their lifespan is long, and the xenon cold light sources lifespan is less, but it is less costly, and LED cold lights are costly, very costly. So the fiber optic cable and the condensers are used. So what is white balance? So white balance we'll see by putting a gauze inside the light source. The entire screen should be white. What is the purpose of white balancing is that it makes the basic colors of light are red, blue, and green. These three basic colors are mixed in equal proportion to form white. So for example, if a gauze is with the betadine is seen for white balancing, the yellow color will be it is considered as impurity by the camera, and it would be removed by the white balancing system camera. But after removing, if you are doing it with that betadine, and after without betadine, you see that yellow color will look as blue. So the entire screen should be white for the perfect white balancing. Otherwise, the system itself adds some color to make it white. So if with betadine, if you are seeing white balancing, and again if you are going into the abdomen and you see momentum, and that yellow color looks blue for you. So this is the importance of white balancing. Next, I go to the telescope. Telescopes are of varying size. Three important properties of telescopes are the size. Diameter of the telescope varies from 1.5 mm, which we use in the office hysteroscopy, and up to 15 mm telescopes are used. For pelvic surgery, we commonly use 5 mm, 7 mm, and 10 mm scopes, and 12 mm scopes are used in robotic surgeries. And the degree of the telescope. The telescope can vary from 0 to 120 degrees. The commonly used angles are 0 degree, 30 degree, and 45 degree. So what is zero angle is, you can see this oblique cutting of the scope. The angle between the longitudinal axis of the scope and the longitudinal optic axis is 30 degree in 30 degree scope. And in 0 degree scope, the optical axis and the longitudinal axis of the scope are the same. So what is the advantages is 30 degree. For 0 degree laparoscope, we can see the panoramic view. But if you want to see a particular area of interest, 30 degree scope is useful. This is the light post where we attach the light source. So in 30 degree scope, you can rotate the light source. For seeing pathologies on the left side, you can turn the right source to the right and the vice versa. For viewing the anterior abdominal wall, you can turn the light source down. And the third one is the rod lens system, which are inside the telescopes. Usually 16 to 18 rod lenses are used to magnify the image. The number of rod lenses varies with different make of the telescope. So this is the proper positioning of how to hold the camera. The thumb should be on the buttons, and you can see my hand between the index finger and the middle finger. You hold like this. And the light cable should not bend. It should form an arc. This is the proper position of the holding the camera. So coming to the next is the gases commonly used are CO2. This is the gas insufflator. Next
5 more minutes, Kana. So
okay, ma'am. So this is the flow rate. This is the set pressure we set for the instrument, and this is the pressure inside the abdominal cavity. Commonly used pressure is 15, and the gases used are CO2 is the most commonly used gas because it is readily available, cheaper, easily absorbed by tissues, and quickly reversed via respiration. So these are the contraindications for lab. Next, we are going about the anesthesia for the surgery. These are the contraindications: cardiopulmonary disorders, DVT, renal disorders, pulmonary thromboembolism, cirrhosis, intestinal obstruction, and multiple surgeries. Trauma and hemoperitoneum, malignancy, and pregnancy are not considered as contraindications in expert hands. These are the physiological changes that takes place due to pneumoperitoneum. CO2 causes, as you all know, hypocarbia, acidosis, and hypoxia. Pneumoperitoneum exerts pressure on the IVC, decreases the venous returns and the cardiac output. So for prolonged surgeries, we use the compression stockings to prevent DVT, as there is a long period of venous stasis. These are the mechanical effect on the pneumoperitoneum, the cardiovascular system and the respiratory system. And renal also, there is a significant decrease in the GFR. So airway management, as we all know, mechanical ventilation, ETCO2 tube, and adequacy of ventilation should be checked. The TV monitor, we use a HD monitor with 20 inches, preferably with a video recorder. So next is the patient positioning. For all gynecological procedures, we use a semi-lithotomy position for manipulating from the downside, and with a Trendelenburg position with a mild head low. The important thing to notice is the angle between the thigh and the supine position should be obtuse. This angle should be obtuse. So next is the axis. We have the open technique and the closed technique. Open technique is what we do in like a puerperal sterilization. We open directly the rectus and insert the Hansen's cannula. And the closed technique, we use the Viris needle. We all know about that. It's a 2mm needle. Previously, it was used for draining the pneumothorax. For proper entry into the abdomen, we have to aspirate and see whether any fluid is coming, whether blood is coming, to confirm any injuries, bowel or blood vessel injury, and hanging drop test and the free flow of saline should be checked. This is the Viris needle. Before inserting, we should check the spring action of the Viris, and we should inflate the saline and see whether there is a free flow. So for the entry, primary entry, these are the various positions used. The palmar point is used. It is 3 cm below the left subcostal border, and the midclavicular line is the virgin area of the abdomen. We can use it for patients with previous multiple intra-abdominal surgeries. And before putting palmar point incision, ensure that the stomach is deflated with the Ryle's tube. And we can use infra-supraumbilical port and epigastric region in the midline. various types of trocars, the cutting and the non-cutting. This is the sharp trocar and the blunt trocar. Blunt trocar is also called as the safety trocar. It has an obturator. You can remove this obturator, and this is the body and shaft of the trocar. So next comes to the ergonomics of laparoscopy, the port position. For contralateral surgeons, the baseball diamond concept is used. This is, we can keep the hand like this. So this is like a diamond, and the tip of the index finger points the target organ, and this thumb points the light source port, camera port, and the anatomical snap forks on the both sides that points the secondary port locations. This is used for whichever the target organ, uterus in case of hysterectomy, appendix in case of appendicectomy. So this the concept you can use for contralateral surgeons. Ipsilateral surgeons can use the arc. The arc should be drawn with the length of the instrument. Half the length of the instrument you can draw one circle, and 2/3 of length of the instrument you can draw another circle. In the second circle, in the midline, you can put the camera port, and in the first circle you can put the other working ports. The distance between the working ports should be at least 1 palm's breadth. And these are the important angles in laparoscopy. Manipulation angle, it is the angle between the two operating instruments. In case of contralateral surgeons, it should be 60 degrees. And the azimuth angle in case of ipsilateral surgeons should be, it is the angle between the light source camera and the operating port. It should be 30 degrees. And the elevation angle from the abdomen and the instrument should be 60 degrees. These are the ideal angles. And for ergonomics, for proper ergonomics, the height of the table should be at the level of elbow of the surgeon. The screen should be at the level of head of the surgeon, and the distance should be at least 6 feet from the surgeon. So these are the instruments used in laparoscopy. This is the atraumatic forceps, Kelly's forceps, grasper. This is the monopolar hook, and these are the different straight scissors, curved scissors. And these are the general instrument and with different types of locks we use. The sheath, this is the sheath, you can rotate is 360 degree to obtain the desiring angle. So these are the new energy sources used in laparoscopy. We use the ligature, we have the bipolar, monopolar and coberidian, and the cutting bipolar, and this is the harmonic device. So recent advances is the natural orifice transluminal endoscopic surgery. The spider is a sterile disposable device that contains 4 working channels with 2 flexible instruments and 2 rigid channels for operation. And single port laparoscopy, where the single port with different different instruments can be used in the single port, but it has a freedom of hand movements is restricted in this case, hence it is not that much popular. So advantages of laparoscopy are, as we all know, less pain, less hospital stay, minimal scar, early ambulation, magnified view, reduced risk of infections, and less chances of incisional related complications. Disadvantages, it requires a long learning curve. Thank you so much for the patient listening.
Yeah, it was a wonderful presentation, Doctor.
Thank you.
Yeah. So, what about the incision in obese and thin ladies? I mean, entry.
The Viris size we can vary. It is we use short Viris needle in obese and length 15 centimeter, and longer Viris can be used in obese ladies.
So, what is the complication in thin patients? How to overcome that?
In thin patients, you should actually the length is very less. So single prick with single actually for after entering we have to have 2 clicks. After the first click itself, we have to lift the abdomen with 2 alleys, and then we can enter to avoid injury to the bowel and the underlying great vessels.
Any other method?
Open technique you can go.
Yeah.
Open
So
the rectus and
yeah, that would be ideal. So among the various sites, which is in obese, which is the least, which is the place which incision is better, whether it is infraumbilical, umbilical, or supraumbilical?
Infraumbilical.
Where the failure rate of entry
only 1 layer to pierce, and we can.
Where?
Infraumbilical
It
or
is not in,
supraumbilical, just around the umbilical, above or below.
no, it is at the base of the umbilicus. It is umbilical. Okay, it is not.
That's what
It is
I mean.
not infra or supra. It is through the umbilicus.
Yeah,
okay?
yeah. Yes.
So that is a place ideally, and that is expected to be the least. Additions are expected to be less at that point,
Yes.
right? And what about pediatrics? Any note about pediatrics laparoscopy?
In pediatrics, the instrument size length will be less, ma'am. Telescope, we can use smaller diameter telescope, and in pediatric also we can go for open technique to prevent injuries.
So the main thing is bladder will be intraabdominal. Okay, so that is one thing.
Bladder
we
should
need
be
to
drained
know.
before. Yes, ma'am.
Yeah, and one more is the pressures to be kept at the lower. So, okay. Otherwise, it was really good. Our overall presentation was.
Thank you.
Thank you.
Thank you.
Good presentation, Siraj. You have covered the major instrumentation which is involved and the ergonomics too.
Yes, ma'am.
Routinely use direct trocar entry or using VIRIS?
Ma'am, I am using VIRIS, ma'am.
Okay. So
Any difference in the complications?
Ma'am? Sorry?
Sorry.
Shanti, continue.
Yeah. So is there any difference? Why do you prefer VIRIS? Like what are the reason why you prefer VIRIS needle rather than direct method?
Actually, I'm trained in that way. I'm a student of Damodar Rao, sir. I'm a student of Dr. Damodar Rao.
Is there any difference in the complications between the direct method and the VIRIS method?
Actually, not much of complications with the direct method, ma'am. But we find it we find it little difficult with the open technique in obese patients and all with much fat. In that case, VIRIS is helpful for us.
Oh. Okay. Thank you.
Thank you, ma'am.
Any more questions, Dr. Karthika?
No. Okay, wind up the session.
Okay.
Thank you.
Thank you.
Thank you, speakers, Dr. Belinda and Dr. Siraj Fatima. And thank you, Karthika madam and Shanti madam. Wonderful presentation. Now let's move on to the next discussion. That is surpassing the roadblocks. The fundamentals of total laparoscopy. So sorry, Chairperson Ramani Devi ma'am is not here now. She has an urgent appointment. So I will introduce the speaker, Dr. Sumana Manohar ma'am. Sahiti, can you please display the CV? Thank you. So we welcome the speaker, Dr. Sumana Manohar ma'am, who is from the Apollo Hospitals. She's a consultant obstetrician with subspecialty interest in fertility medicine, endoscopy and robotic surgery, high-risk obstetrics. And she's been the AICC RCOG South Chair since 2024 and also Scientific Chair for APAGE 2024. And she's the program coordinator for MGR Fellowship Program in Reproductive Medicine and invited faculty at national conferences. She has several publications in national and international journals, and she's a Part 3 MRCOG examiner, and she has a passion for teaching the postgraduates. We welcome you, madam.
Thank you, Kar. Thank you, Radhika.
Thank you, ma'am.
I'll share my screen now.
Yes, ma'am.
Can you see me? And here. Yeah. So basically, how to surpass the roadblocks, what we face in a total lap hysterectomy. Actually, they have taken off that hysterectomy in the printing. So basically, I'm just going to cover what difficulties we can face as we do a total lap hysterectomy. Straightforward hysterectomy, it's no problem. As we face, what are the difficulties? The scope of my talk is going to be on redefining fundamentals of performing TLH, what difficulties we can face, and how to predict, prevent, and surpass the difficulties as we face it. How do we strategically plan for a better outcome? The challenges as we go along, we can face adhesions, we can face a patient with a large uterus, we can have difficulty in removing the uterus in pieces like tissue extraction. or it could be endometriosis, which can be a nightmare sometimes when we face the stage 4, and difficult manipulation. If you have a postmenopausal woman, you want to do an endometrial CA laparoscopically, we can have difficulty in manipulating the uterus where the vagina is really atrophic, and we have to choose our instruments depending upon the accessibility, the availability, and the size of the uterus. And of course, obesity is another problem what we face nowadays with the high BMI. We can have difficulty in entry and treating them as well, because the obesity again we can face a lot of challenges. So I'll just take through case scenarios where it's a 45-year-old lady who's complaining of severe menstrual cramps, heavy bleeding during her periods. She had several medical treatments, including Dynogest, which was the last 6 months with no effect. She had 2 children by cesarean section. Clinical examination suggested the possibility of adhesions anteriorly, and pouch of Douglas was free. So it's very important to examine the patient clinically before we post for a total lap hysterectomy. She had ultrasound scan which showed severe adenomyosis and possible adhesions anteriorly. She had 3 iron infusions in the past, and currently her hemoglobin is 8 grams. So there is a good indication for her to have a hysterectomy. She has severe adenomyosis, her hemoglobin is low, and there are adhesions, and it's a previous cesarean section. So you mentally, physically be prepared and investigate her further to find out what exactly we should be doing. So the use of ultrasound sliding sign for the prediction of adhesions in women undergoing repeated section is very important. You do a transvaginal scan and transabdominal scan. A sliding sign, which is absence of it, could be an indication that the bladder is really adherent. And sometimes the bladder will be so adherent that it can be invading into the cesarean section scar and into the muscle layers as well. Rest of the signs of bladder adhesions, adherence, and the extent can be found out by the horn sign, where the bladder can be really adherent to the uterus, and you can just see 2 horns which are like this on the ultrasound scan, and sometimes the papillary extensions can be there inside into the bladder. So you have to be mentally be prepared when you enter this sort of a situation. A safe entry has been covered very well by Siraj. I wouldn't take too much of time on that. Palmer's point is the one which we all should be entering, and Hassan's technique when there are a lot of adhesions, a previous tuberculosis, or any previous surgeries like laparotomies or any intestinal surgeries, better to go for a Hassan's technique. But then again, the reports have suggested that it doesn't really prevent us injuring even with an open surgery. Li Hung point is another thing which we can use in obese patients, where it is in the midline. When there are lots of adhesions, it can go a little higher up, and we can use the Li Hung point. And the Jane's point is another one which I will cover. So Palmer's point, as Siraj said, is 3 centimeters below the costal margin in the midline. Usually it is safe. We empty the stomach, and then we look for the liver, look for the spleen, and see whether there's any splenomegaly, etc. earlier, because malaria being very rampant in our country, we have to make sure there's no spleen, there's no fullness of the stomach. We have to look for the resonance, and then make sure that you put your varus needle 3 centimeters below in the mid-clavicular line. Li Hung point is midpoint between the umbilicus and the xiphisternum. And the similar advantage to Palmer's point, but with the midline anatomy, which may ease entry in the obese patients. Panoramic views, especially with the large uterus and adhesions, it is better to go for a Li Hung point. And sometimes if it is really stuck, posterior vaginal fornix is another one where we can get into, or uterine fundus also we can try. These are the other things when we have a midline scar. Jane point is around 10 centimeters away from the anti-superior iliac spine, and 10 centimeters away from the umbilicus, and 2.5 centimeters away from the anticipiliac spine. If you have anticipiliac spine here, 2 centimeters away, 10 centimeters above, and 10 centimeters lateral to the umbilicus. This is where the Jane point is. There are several studies which have shown that the Jane point may be a safer point, especially when they have midline scars and also lots of adhesions inside. But the risk of injury to the epigastric vessels can happen sometimes because we cannot really visualize the lateral part when it's really left laterally placed. So this is the patient where we said 45-year-old. She had adhesions and the scan suggested there was adhesion. This is the roadblock which we can face. Ventrosuspended uterus and the bladder is quite adherent and we can have this. So problems we can face in this is significant hemorrhage because the uterus is really stuck and it could be quite vascular. Prolonged surgery, it may take longer time. Unrecognized thermal injuries to the bladder to give us a late onset fistula. So usage of electrosurgical instruments, we have to really cautious. I don't normally have a monopolar on my table because of the spread is much higher, and I do use harmonic scalpel. So in a scarred uterus with the dense adhesions and fibrosis between the bladder and the lower part of the uterus segment, pushing the bladder down in the midline can cause unintentional bladder injury. So it's always better to have a lateral dissection of the bladder, which is always safer in an open surgery or in a laparoscopic surgery or in a robotic. Lateral dissection of the bladder and lift the bladder away, go more caudally, lift the bladder away would be the safest approach in a previous cesarean section where the bladder can be really pulled on, especially when you have a ventrosuspended uterus and also when there are fibroids, it can be really pulled on. So when you have something like this, where the bladder is really adherent to the uterus, we can actually go between the superior vesical artery and the uterine artery. We can create a layer caudally and then go up and push it with the back of your bowel handling forceps, which is the ideal instrument I found, which we can use. So this is the bladder holding this is the bowel holding forceps, which can be really safer, and the curved one where we can actually use it and lift up the bladder with that and then cut with a harmonic scalpel the adhesion, which will give us a better dissection. So it has been reported that the overall rate is around 1.59% and 0.56% of urinary tract injuries when we have a previous cesarean section and we attempt to do a total lap hysterectomy. So this is a lady where we had the omental adhesions which were removed with the ligature. When we pull on the omentum, we can see the adhesions and we can see the cleavage much better. So stretching the tissue, which will really help. So you've got both the round ligaments, and now I enter the space. The other side, it's separated, and cutting the uterosacral ligaments posteriorly will give that leverage for us to go anteriorly. So posterior peritoneum, if you just divide that posterior peritoneum posteriorly and cut your uterosacral ligaments, you can see my the bowel holding forceps is going between the uterine artery and the bladder pillar, superior vesical artery. So that space will be there. So if I can't find it higher up here, I can actually go down here, a little late down here, and we can create that space there in between the bladder and the uterus. So somebody has to really stretch. Stretching will prevent you from injuries. Sometimes the bladder can be double folded and adhesions can be there. So the God has created the spaces. So if you stretch, automatically you can see the cleavage. That's very, very important that you stretch and get into the right cleavage. And normally, if you stretch and get into the right cleavage, they never bleed. So you go into that space and create that space. See, when I pull, automatically bladder separates. So once you get into the lateral layer, And once you know your bladder is away, then you can actually use a myoma screw to pull the uterus, and then you can separate the bladder beautifully. Yeah. So now you suture it. So when you actually, so that's how the bladder separation can be done. Spacing between the bladder and the vaginal cuff is also very important to prevent bladder injuries and causing fistulas, because at least they should be 2.5 centimeters away from your vault. When you actually separate the bladder, you have to really push it down so that there is a separation of the bladder is not on the way when you actually suture it, and you do not land up having fistulas. So this is the second case scenario, 45-year-old, 22-week size uterus with multiple symptomatic fibroids. So that she needed surgery. So the risk of malignancy we should be aware of because of the age factor, size and the number matters, accessibility limited because of the big uterus and the bleeding can happen. These are the concern. Accidental bowel and urinary tract injury also can happen because you cannot really see everything properly. Extraction is a difficult, tissue extraction can be difficult, and the duration of the procedure can be on the longer duration, where you can land up having other issues, anesthetic issues, venous thromboembolism, etc. So the few facts is the risk of uterine sarcoma for a normal looking unassuming fibroid is around 0.49 to 0.041%. Under the age of 50, we have to counsel the patients that there is 1 in 400 chances of a normal looking fibroid on MRI and normal LDH level. We have to tell them that the risk is 1 in 400. Whether you want to go laparoscopically or you want to go open, it's very, very important to counsel the patient and tell them about the morcellation also doesn't prevent you from having a spread. And if it happens to be uterine sarcoma, which can happen in 1 in 400, there's always a chance of it spread, and the risk is much higher. The prognosis is much poorer. And around the menopause, it's around 6 in 1,000 procedures. So the uterine size, the ultrasound, other radiological examinations, your LDH levels cannot predict malignancy all the time. No reliable biochemical markers are there for sarcoma. So when you counsel them, you have to tell them this and take a consent that there is a risk when you're doing a total lap hysterectomy and wanting to contemplate on removing it laparoscopically for a 45 to 50-year-old age. The risk of dissemination of the fibroids, intraperitoneal dissemination, when you morcellate, there's 1 in 120 to 1 in 1,200 chances. And peak incidence of sarcomas is between 50 to 55 years, which they have to be aware of. And more than 60 years, it's almost like 7.5 to 15.3 in 1,000 cases. If it is more than 60 years old, don't even contemplate on doing laparoscopically, you just go for open. When you are between 50 to 55, you can talk to them and tell them and whatever the patient wants. Between 45 to 50, also you have to counsel them on what the risks. This is very, very, very important. Port placements, I'm not going to repeat it, which Siraj has already told. And Gayatri, I think, was asking about the pediatric 28 centimeters long instruments, 14 centimeters inside, 14 centimeters outside can be used. Unlike the adult, which is around 36 centimeters, it can be 5 centimeters away from the main port. So it will be easier. So when you have something like a large uterus like this, you can use a double manipulation. You can use a myoma screw from higher up, and you can use the whatever manipulations you are used to normally, either V-Care or other manipulators which are used to, you can use it. So once you pull on that, again, the same way you get your posterior peritoneum. Not all of them do posterior peritoneal separation, but I normally do because it gives us skeletonization of the uterines much better. And then once it's pulled up, everything is just simple. Like you remove your, separate your bladder by using harmonic scalpel. if you have. Otherwise, you can use the monopolar as well under coagulation setting, not on the cutting setting, if at all you're using monopolar. And you separate the bladder, which goes well once the uterus is pulled up through with the Maiama screw. So as you see, I use the harmonic scalpel to buzz all those vessels under coagulation current so that it doesn't bleed and it doesn't look messy. So you can just beautifully separate that and move the bladder down. And as soon as I see the vaginal nonculator, I stop. 2 centimeters below, I stop that. Yeah, that's what is done. And then once the uterus is, we can pull this way, that way with the Maiama screw and bipolarize the uterines. Posteriorly and anteriorly, have a look. It's like a clamp, you should put it on and have a look. And so that now with this, when I push the bladder down, the ureters also go down, and then you can open up the vault with the cutting current of the harmonic. So once you removed it, you have removed the uterus, then vaginal morcellation is another task where you have to make sure you have deep, long, lengthy speculums like I showed in this picture. It's very, very important. And first you cut the cervix intact, because it's very important for them to see, the pathologist to see the squamocolumnar junction, transformation zone, etc. So you have to cut the cervix separately and remove it. And then with the reverse C-shaped cutting, you can actually pull on one side and extract. Even this is not going to prevent from spilling. So that also patients have to be told. And then once you know that it is coming out, with a little bit more relaxation, we are done. So it doesn't prevent spread of cancer cells into the abdominal cavity, even by doing vaginal morcellation. This you have to tell them. Other thing is in-bag morcellation. Several in-bag morcellators have been in the market, and the risk of dissemination again cannot be monitored. You have to remove the fibroid. That fibroid will go around the whole peritoneal cavity, and then you have to put it in the bag. So nothing is going to really prevent you from, unless you remove the uterus intact with the fibroid inside. That's when you can guarantee that the spread is not there. The risk of dissemination cannot be guaranteed even with the in-bag. All this vaginal morcellation, in-bag morcellation, we are reducing the risk, but we're not preventing the risk, which patient has to be told. So in-bag morcellation, you distend the bag, and once you know the technique of it, it's quite an easy procedure. The whole bag gets distended and you morcellate it under vision. And you make sure that the morcellator and the fibroid is in the midline. Anytime when you're actually doing the surgery, you make sure that your the surgery where you're doing is in the middle of your view. And then you remove you tie that knot there on the other side where the scope went in. And then you remove through the 10 mm port, which is on the side. So then it comes the ureteric injuries. 3 steps which will prevent us from having ureteric injuries are peristalsis and visualization of the ureter. Doesn't mean that we have not injured the ureter. The cut ureter also can move. So ligation of the ovarian arteries should be done, which is infundibulopelvic ligament, where the lateralization and visualization should be done. And when we ligate the uterine arteries, by pre-ligating we can do, or uterine manipulator, which will make the ureters to go down. Dissecting the bladder down will move the ureter down, and closure of the vault, visualization and precision of closure is very, very important. So in this lateralization, you can see you have to cut the round ligament, go along the infundibular ligament, parallel to the infundibular ligament. So when you lift your infundibulopelvic ligament, your ureter is just down there. You can see that. Yeah. So you've identified ureter higher up, especially patients with endometriosis, any other adhesions which they have. It's very important that you lateralize your ureters, and then you see the ureter moving, and then you clamp. Uterine arteries, as I said, we have to push the bladder down, and then we have to cut the uterines. Normally what happens is when there's a big uterus, the ureters can be pushed cephaloid by the uterus. So we have to make sure that the posterior peritoneum is cut. You move the posterior peritoneum down, you move the anterior peritoneum down, and make sure that the uterines are well skeletonized, and then you put your bipolar. Then the risk of injury to the ureter is not there. And during the wall closure is another area where we can injure the ureters. So you make sure that you take the bites very close to the uterus, very close to the wall, around 1 centimeter away apart and 1 centimeter below. Vertically and horizontally, you should give 1 centimeter distance, then you're good. And when you're actually taking the angle, you should make sure that the ureters are away and the bladder is down, and you take the angle so that the risk of vaginal bleeding is also not there. Because of the larger duration, the increased risk of thrombus and neurological problems can be there. Mobilization of the patients and patients' legs change every 2 hours. A padded stirrup should be used. TED stockings and SCD usage should be done. Endometriosis is another nightmare where we can face frozen pelvis, adhesive nature of the disease, obliterated surgical planes, distorted ureteric anatomy, and adherent bowel. So distortion of the normal anatomy, this is how we face it, especially the ureters and the uterine vessels. Everything will be pulled together. And meticulous adhesivolysis is important to avoid the damage to the periadventitial vessels, parasympathetic nerves running caudally and cranially to the ureter. Risk of voiding dysfunction can happen. So it's important that the nerve sparing should be done when we are actually doing it, not to extend below the level of deep uterine vein to spare the pelvic plexus. So this is a lady with a grade 4 endometriosis. Everything was stuck with everything. Slowly you have to get the planes. Normally the dictum is you separate the bowel, which is on the left lateral side, go down, and then you go down identify the round ligaments, and then the bladder adhesions and the bowel adhesions we have to separate properly. The sharp dissection is much better. Better not to use any thermal dissection here. As I said, if you go to the right planes, then you will get the right dissection. You will not have any bleeding. And as I said, if you actually pull on the tissues and push on the tissues, see the plane comes. I'm using 2 instruments so that, one is pushing on the bowel and one is pushing on the bladder. I am pulling on the bladder, pulling on the bowel. So the plane comes. Obesity is another problem. VTE prophylaxis should be given. Low molecular weight heparin can be given. Antibiotic prophylaxis, patient position is important, and longer instruments should be used. 15 centimeters Veress needle with an angle of insertion at 90 degrees. Palmas point entry is okay. Umbilicus is actually pushed caudally, so it will be very difficult. So Lee Hung point also is a Lee Hung insertion also is a choice in this obese woman. So take home messages: practicing lateral window technique in hysterectomy with the previous cesarean section. If you're doing open, you can go laparoscopically as well. Placement of ports are important in a larger uteri. Endometriosis, we have to go systematically. First, go for the left lateral, remove the sigmoid colon, remove the adhesions between the sigmoid and the lateral pelvic wall, and slowly identify your round ligaments, and then go for the deep infiltrating endometriosis gradually. Tissue extraction, more usage of in-bag should be done for fibroid uterus after appropriate consenting. It's very, very, very important that we morcellate in-bag for all these fibroids, which are between 45 to 50, because we will face with surprises one day or the other, and which we have done, and I have seen patients where they can land up having sarcomas, atypical fibroids, fibroids with little bit of more mitosis, all that which will be problematic at later point of time. And if you disseminate that fibroids by not doing in-bag morcellation and you morcellate inside, you can land up in problem. And as I said, prognosis is very poor if you have a patient with this, with the disseminated fibroids, if there is a suspected sarcoma or high-risk myomas. Thank you very much indeed. Thank you, Sampath, for giving me the opportunity.
Thank you, Sumana ma'am. Very wonderful, excellent presentation, and very useful tips for us, ma'am. Thank you so much, ma'am, for the videos as well, and very interesting. And we will move on to the next session, panel discussion on safety in endoscopy.
Ma'am, quiz questions, ma'am?
Yeah, yes. Okay, we'll have the quiz questions now.
Yes.
Aditi, can you please post the questions?
Yes, ma'am. First question.
Entry into the left upper quadrant, 3 centimeter below the left subcostal region, along the midclavicular line. So what do we call them? A, Palmer's point, B, Jane's point, C, Lee Hung point, D, none of the above. So the hosts and the panelists cannot vote.
Last 5 seconds. Time up. Second question.
Second question. Complications during laparoscopic hysterectomy. This is an easy question. Hemorrhage, urinary tract injuries, bowel injury, all of the above.
Five more seconds. Time up.
Thank you, Saiti. And thank you all. Let's move on to the next session. It's a panel discussion. I welcome Dr. Vanita. Madam is a medical director, Sunrise Laparoscopic Center, Chennai. And she's a teaching faculty in EASC, Chennai, managing committee member OXI between 2021 to 23, EC member of TNIAGE 2019 to 22, coordinator of South Zone FOXI Endoscopy Committee between 2021 to 24. And she has numerous publications and awards. Winner of FOXI Dr. Yuli Rudra Sinha Award, ACOG 2011, and Best Doctor GPS Society 2018. Best paper in 14th International RCH Conference in 2004, and operating faculty in live endoscopy workshops. Presented several papers in national conferences, and she's coordinated the pre-congress workshop in basic laparoscopic skills, OxyCon 2012. Welcome, madam.
Thank you, ma'am.
Thank you, ma'am. Our next moderator is Dr. Meenakshi Sundaram, madam. She's the OXI treasurer and Tamil Nadu IAG joint secretary, course coordinator, endogynecology fellowship in Tamil Nadu Dr. MGR Medical University. And she has a diploma in advanced laparoscopy, Men's Hospital, Mumbai, and diploma in gynecological endoscopy, Kiel, Germany. Robotic training at Celebration Hospital, Florida, USA. She's the gold medalist under graduation and in post-graduation from Tamil Nadu Dr. MGR Medical University. And she has extensive publications in peer-reviewed journals and several book chapters. Welcome, Dr. Meenakshi Sundaram.
Good evening, everybody. Thank you, madam. Thank you for the warm introduction.
Thank you. And can you please introduce Dr. Madhumita Arun Karthik? Or I'll carry on. Okay.
You can.
Yes. So she's a consultant Opsum Gynae in reproductive medicine, Salem, treasurer of Salem chapter of TAPISA, EC member, ISAR Youth Brigade, peer reviewer of JOGI, editor of official newsletter of Midlife Management Committee, and she's also editor of OG Source, assistant coordinator in online ART course, and FOXI has talent South Zone coordinator, and also won the FOXI Award and Superstar Award in 2019. She has international publications on ART. Our next panelist is Dr. G.R. Tarani Priya, is a consultant managing director from Tharani Hospital, Chennai Malai, treasurer of E-Road OG Society. She's done her UG from Namala University and DGO from PSG. And she's pursuing FRM, reproductive medicine, Community House, Medline Academics. And she is a former senior resident at E-Road Government Medical College. Okay, the next panelist, please. We welcome Dr. Rekha Rajesh Madam, who is a clinical director, Vijay Shrishti Fertility Center, Hosur, Tirupattur, and director, Mathrutva Fertility Center. And she has done her diploma in reproductive medicine from Germany and PG diploma in reproductive medicine, Warwick, and certified high-risk pregnancy specialist from ACOG. She's a life member of ISAR, ASR, IMS because of India. And the next panelist, please. We invite Dr. Vidya Prem, who has done her MBBS from Madras Medical College and MS from Kasturba College, Mangalore. And she's completed a DIP&B fellowship in fertility from Simar Edapal and practicing obs and gynae and fertility at Sri Ganapati Nursing Home and Tamarai Fertility Center, Tirupur. And she's the secretary of Tirupur Obstetric Society and member of OXY, ISAR, and ISHR. Her area of interest is infertility and high-risk obstetrics. So we welcome Dr. Divya Chandrasekhar, who is has worked in government service for 2.5 years, and at present she is a consultant in Muthukumaran Medical College, an assistant professor, and she has experience of more than 10 years in obs and gynae. Welcome, madam, and thank you. So let's the moderators will take over. Dr. Meenakshi madam and Vanita madam.
Thank you.
Thank you, everyone, and welcome to all the panelists for today's session.
Meenakshi ma'am, your voice is very low.
Very low.
Yes, ma'am.
Can you hear me now?
Little better.
Little better.
Yes, ma'am.
Okay. So, welcome to all the panelists for today. So basically, this panel was on safety in endoscopy. I think in endoscopy, one of the most important thing is to avoid complications. So as you learn the basics, it is important to also ensure that at every step, because it's so technologically challenging as well, you should avoid complications as much as possible. So that's what we're going to cover quickly, four or five important scenarios. Me along with Dr. Vanita, I'll share our screen. I think all the 5 panelists are here, right?
Yes, ma'am.
All right. I'll just share screen.
Ratika, are you there?
Yes, ma'am.
Yeah, okay, ma'am.
Okay, you can see my screen?
Yes.
Yeah. All right, so we just labeled this as flirting with disaster. So basically, first is do no harm. So that is what the aim of the panel is, just to highlight certain features, certain important steps when you do laparoscopic surgery. It is important to follow these safety principles to do the surgery without any complications. I hand over to Vanita to start our first scenario. Vanita.
Yeah, thank you, Meena. Yes, the saying goes, anything well begun is half done. The same applies to laparoscopy also. The first most important step is to enter the abdomen safely. Once you're done that, you have done a diagnostic laparoscopy safely. Okay. And then all of us know more than 30% of complications are related to entry. And I think Dr. Siraj highlighted it very well and she discussed it in length. So it's going to be a reinforcement again in the panel. Okay. So we just go on to the scenarios. See, it could be trocar-related injuries. It could be either vascular or visceral. And sometimes the technique itself you need to learn and practice at least 2-3 techniques, because once something goes wrong, you will always have to fall back on something. So you need to know how to do an open technique and closed technique. So sometimes you are not able to enter in 2-3 times from the same point. You have to change the technique, and sometimes also the site of entry. These are things which you should really learn in the learning curve. I always say, learn everything, practice 2 or 3, and follow one. Okay. So when you are not able to enter through the varies,
Then the close technique, and you've done 2-3 times, and your abdomen starts tenting and you're not able to get in beyond the pre-peritoneum. That is when your Hassan's cannula or your open technique comes to place. So always learn the different techniques of entry. Next slide, please.
So maybe we can ask the panelists what are their
Yeah.
views on entry.
Yeah. Can each of you please tell us which technique do you prefer, whether closed or open, and how do you prefer to do it, and what trocar do you use, and the site of entry, what is the advantage and disadvantage you have in your practice to follow that?
I use
Any of the panelists can answer, and I would be happy for each of you to give your view.
so I use a blunt entry. I don't use varies. I use direct entry blunt with blunt trocar. And my first, the port of entry is usually supraumbilical. And in severe adhesions, I use Palmer point. So because I initially
In
started, I
obese
was using
patients
varies.
also, are you very comfortable?
So now
In
I'm
very
used
obese
to
patients, are you comfortable
initially I
using the
had
blunt?
yes, ma'am. Initially, I had difficulties when I started with, but now I do easily with direct entry.
Okay. The other panelists, would you like to give your opinion?
Actually, I use closed entry, ma'am. So initially, I use the venous needle entry, then followed by
Not able to hear you clear. We're not able to hear you clearly. Could you please come again?
Mostly I use the close entry technique, ma'am.
Yeah.
And in case of any difficulty, I proceed with the blunt. But most
Your
of the
site
times,
of
the venous entry
your site of entry?
it'll be in the base of the umbilicus, ma'am. Not the skin
Okay.
below the umbilicus, it will be in the base of the umbilicus.
Okay. For bigger uteri or patients with previous surgeries, would you
I'll
prefer
use
some other point?
umbilical.
Okay. The other panelists? How many of the panelists are logged in?
Dr. Madhumita is there?
Yeah, but she's traveling actually. She's in the train.
Dr.
So I don't know.
Actually, it's me.
Yeah, that's you. Okay, Dr. Rekha.
Dr. Rekha, let me just check.
Dr. Vidya.
Yes, ma'am, I answered.
Okay.
Okay, so we have Dr. Vidya and Dr. Dharni alone.
Dr. Divya Chandrasekhar, that is our fifth panelist. Avanga irukangla?
I don't think she's here.
Okay, so basically it's two of us against two of you, is it? All right, so that makes it easier.
So anybody would like to, elaborate on how you do your varies entry? Out of the two, any one of you?
So I think one is following open, one is following close. So you can just tell what is your way of doing it.
So, ma'am, I use blunt trocars. I don't use varies. So I just make a small, around maybe 10 mm incision supraumbilically, and sometimes, and then in case of adhesions, I use Palmer's point. I make the incision and then I hold the lower part of the abdomen, pull it up, and then I introduce the direct, and I follow the direct technique and introduce the trocar. And I introduce my optical port to check whether I have entered right, and I inflate with, and I create the new peritoneum.
Okay. Always make it mandatory to drain the bladder, which is very important before doing the entry.
Yes,
this is for the benefit of the delegates who are watching this.
Yes, ma'am. Both bladder drainage and ensuring that the patient is in straight supine, not in Trendelenburg. Both I
Yeah.
ensure.
So always giving a head low position before the trocar entry can bring the major vessels in more and close to the entry point. That's the reason you have to pay the patient supine. The other panelists, would you like to speak about varies entry?
Ma'am, before I put the venous needle, I'll make sure that the venous needle has the spring action, and I'll just
Very
hold the
good.
abdomen, and I'll put the needle in the 90-degree position, ma'am. And we'll inflate it with minimum with a pressure of 20 to 25 mg, and followed with if the pneumoperitoneum is created, I'll make it with the port entry.
This 20 to 25 millimeter, I don't get it right. Could you please explain more on that?
While we are using the venous needle, we'll make sure that the pressure in the intra-abdominal pressure should be maintained in 20 to 25. Once the trocar has been changed, then pressure should be reduced to 12 to 15 mm.
No, as such, the caliber of the berries is going to be very thin. Even if you're going to put it at 20 to 25, gas doesn't flow at that rate, okay? You set intra-abdominal pressure. I think Meenakshi would also comment on this. We don't think at any point we put it above 20.
Yeah, so a
What
setting
will your
from a
opinion?
pressure of 14 or 15 should be sufficient.
Never ever beyond 20. That is when we try to do that basketball technique and we really want to bloat it up in a very thin patient or sometime like that. But because this is going to give the message across, always keep the pressure at 15, which is very good for entry. And then if you have the anesthetist giving you a warning call, you can get it down to 12 or 13 to operate, or you have a younger pediatric age group patient, you can get it down. And the flow rate also, it's better to keep it at a higher rate so that the abdomen doesn't keep sinking in again and again.
Okay, ma'am.
Okay. Yeah.
Okay, ma'am.
So now that we have entered the abdomen, have we done this entry safe, or yesterday we had a plane crash, or is our entry going to crash anywhere? Is the thing that now we'll have to go through. Let's look at the scenarios. Can I have the next slide, please?
So just Vanita, if you just want to, before we go to the vascular injury, brief about the few points for the entry technique.
Yeah, all that has been done lots by the previous speakers. Meena and Dr. Sumana Madam has done in detail. So I think we'll not have to do it again.
All right, fine. So the only other thing about entry which I wanted to highlight is, suppose if you're not able to put in your varies, or if you're not able to put in at one point, you should always be equipped to have a backup plan to enter from another point. So and also it is important that if you have entered the abdomen multiple times through the same point, and if you have not been able to enter successfully, and later you enter in through another point, you ensure that first wherever you have entered, please look at the bowel or any of the structures adjacent, that you have not hit anything else in your previous entries. So this is something I have experienced, that you put in the trocar multiple times and sometimes it just walks through the bowel and you miss it. So just ensure that if you've not successfully entered through one point and if you used another point, survey the abdomen well before you proceed. So coming to the next part, I think this is what is important. I think why a port entry technique is important is you don't want to first hit any of the vessels as you enter. So vascular injury is one of the most important things, at least as far as port entry is concerned. And the commonest vessel which you could probably hit if you're not entering under vision is the inferior epigastric. So if you have an so first from the panelists, I want to know, how do you put your ports in such a way that you do not injure the inferior epigastric? And second thing is, if you have hit the inferior epigastric, how do you manage it?
So firstly, preferably the midline, my entry ports are all, most of the time it is midline. Or if in situations where I where I am not intending to put in the midline, I see to that it lies either within just paraumbilical, within less than 2 centimeters lateral to the umbilicus. So usually the inferior epigastric vessel anatomically it is somewhere between 4 to 5 centimeters lateral to the umbilicus. So I avoid that. Or I directly go to the palmer's point, where we are unlikely to hit the vascular, blood vessels.
Yeah. So when since your first port entry is anyways, supraumbilical, the chance of hitting the inferior epigastric in that kind of entry is very less. The other ports, especially when you're putting the lateral ports, it is very important that you should view the inferior epigastric, because these ports are going under vision. So you have to ensure that it is not there and then put it. But sometimes even when you view it and put, you may tend to hit an inferior epigastric vessel, because either the patient could be obese, you may not be able to exactly visualize the inferior epigastric on the way. So in case you hit it, so what do you do?
First of all, I view from the other port, lateral port. I first judge from which side it is leaking, and then I just try to push the port on that side, give a pressure effect on the, like how we do in the open procedures, like just we give a pressure for some time and keep like that. I just hold. If it doesn't stop, then I try using cautery. If not, then suturing.
Yeah, so I think you've highlighted all the three techniques that you'll have to follow. When your diathermy works well, I think most of the time you may be able to control with it, but sometimes if it does not work, then you have to be ready to take a suture. You can use the port closure needle to take the suture across the vessel so that it can stop.
Not just at entry, many a times when you try and expand the port to retrieve the specimens also, this can happen. So when you try and expand the port side for specimen retrieval also, you need to be very careful.
So especially the morcellation port and all, when you're expanding, just ensure that the vessel is not in the way. So that's the inferior epigastric vessels. If you can see, it is important when you're taking the ports, like how she was explaining, when you put the port, if you don't put it too laterally, the chances that you will hit is very low. So you try to keep it a little medial, at least your right side port. But anyways, these ports go under vision. So as much as possible, you look at the vessel and then put in the port or angulate the port. If you can't and if you hit it, then you'll have to manage it. The other
The
thing,
dictum is whenever we hit a vessel or a organ, never withdraw the port. Whether it's inside the stomach or inside the vessel, please leave it there. Don't meddle with it. Go in through another port and then visualize where it is and handle it. But the human instinct is to always pull it out first.
so this was, we did not initially see the bleed so much, but it was while specimen retrieval, like how Vanita was highlighting, when there was a port expansion, the inferior epigastric bled, and it took quite a while for us to control that bleed. So either you do a diathermy entry, otherwise, if you can see a pulsating vessel, go and suture it. That will be a better option, so it is safer. Now, the other vessel that you are worried about is especially when you have a direct entry.
Major vessels.
The major vessels. So how do you prevent when you're directly doing an entry into
First,
major vessels?
yeah, first I ensure that the patient is in supine position. Then I hold the anterior abdominal wall and pull it up when I enter. Only these two things I follow.
And never overshoot. When you feel you have had the second loss of resistance, you need to stop there. Many times a woman's instinct is to be very safe and push it an extra length of 1 centimeter, and that is when we go hit against organs. So never overshoot.
Yeah, so the most important thing, like how you've highlighted, is ensure the patient is flat. You don't put the patient in the Trendelenburg and put it, because that brings the major vessels close to the point of entry. And sometimes if you've just made a puncture, a little bit of pressure, wait and watch itself should help. If it is a major bleed, obviously it is like, you have to be prepared to do a laparotomy and open and control the bleed. But the best thing is, you put a gauze piece or put an instrument or something, just give compression on the vessel for some time. And even if you have to buy time to do an open at that point, at least stop the bleeder at one point, because you have, see, this is a thing, one of our 5 mm hit the vessel. Probably it was not really the aorta, it must have been the sacral artery or something. We did give pressure with a gauze piece for some time. Then we proceeded with the surgery. At the end of the surgery, we came back and saw the hematoma did not expand further. You can leave it alone.
Sometimes the vessels in the root of the mesentery can give sort of a picture and look very alarming, and your anesthetist is the person who will also help you, telling you whether the patient is maintaining hemodynamic stability or not. These are things which should go hand in hand. Not necessary that the moment you see some blood and then you feel that you have injured, you have to immediately call a vascular surgeon and open up. We'll have to do that only when the patient's hemodynamic instability happens and you're visibly seeing a spurter there. Okay. These sort of ones, many times they do self-contain and stop.
Especially the retroperitoneal space is quite contained. So if it is in the retroperitoneal space, you can just wait for some time. It usually tamponades and stops. Only if you try and explore it, it can further expand. So you can proceed, you can give some little pressure, proceed with the surgery, come back and see the point. If it's still bleeding or the hematoma is expanding, then definitely you need to intervene. But otherwise, if the patient is stable and you don't find an expanding hematoma, if it was just a puncture site vessel which has probably settled down, you can leave it alone.
The main thing is when you feel you've hit against something, don't meddle with it again and again, because when you meddle it, you tear it further and make the point of entry more wider. So you have a doubt, please stop short, go through another point and check it. Never try to wobble it inside.
Yeah, just some guidelines for trocar entry. Like we discussed, you can have an intra-abdominal pressure around 15 just before inserting the primary trocar. But once your primary trocar is inside, you bring down the pressures to 12 to 15 millimeters. And secondary ports are always inserted under vision once you have achieved the pneumoperitoneum. Inferior epigastric vessels should be visualized before secondary port placement. And once the trocar enters the peritoneum, you can angulate it towards the anterior pelvis.
Ma'am, I have a doubt. Like transillumination, does it, to some extent, does it reduce our lateral port injuries?
Yeah, so if you have like, if you can make that OT dark, and if the abdominal wall also, it matters. If it's a thin patient, the transillumination is very good. Sometimes the patient is very obese, you may not be able to exactly get that view. But in a relatively thin patient, you can see the superficial vessels, but these are mostly superficial vessels. You won't see the inferior epigastric.
They are
Or of
epigastric
the thin
vessels.
vessels, which you can avoid to prevent the bleeding right at the port side. But inferior epigastric is something you will see only under the peritoneum inside. In a thin patient, yeah, I mean, you can see a little more clearly, but it is more of the superficial vessels that you will see in the transillumination, not the deeper vessels. But you can take the incision in such a way that it does not bleed from the skin site.
Keeping the surface anatomy in mind during entry will help us better.
Over to you, Vanita, for bladder dissection.
Yeah. When it comes to urinary tract injuries, we always talk of the bladder, which is more friendly to the gynecologist compared to the ureter, which is more scary. So I go with the simpler one, bladder injuries. The incidence of bladder injury, as we all know, is around 1 to 2%. And again, there are various grades of bladder injury. We're not going to get into all that. Sumana madam has already shown you the various techniques of bladder dissection. So we all know, could you just tell me where are the conditions where you would fear a bladder, and what are the precautions that you would do preoperatively when you suspect that you may encounter a bladder injury?
So any previous surgeries, more
Yeah.
preferably, mostly previous cesarean sections, 2 previous cesarean sections.
Okay.
And in ultrasound, when we feel that there are a lot of adhesions, anterior adhesions, and those 2 cases, we have to be prepared that we may face a bladder injury.
Previous LSCs, previous Shirodskars, previous hysterotomy, and all these are areas where we really need to be very careful. Any previous prolapse surgeries where the PEXIS has been done or laparoscopic cerclage has been done, we have to be wherever the bladder has been handled. The other areas, when you have chronic cervicitis, recurrent UTI, there also you may not get the right play. So if you suspect that, how do you handle them preoperatively? Do you do any special workup? If you feel like you've had previous patient or previous 2 LSAs and you feel the uterus is stuck to the anterior abdominal wall, what are the special precautions do you take during the surgery?
So first of all, electrosurgical unit, better electrosurgical, instead of monopolar, I see to that my bipolars are good. And for bladder, I don't think about, illuminating catheters, I don't think about it. In case of bladder adhesions, I use retraction instead of pushing from below during hysterectomies. I tend to use myoma screws and pull it up so that my vision becomes better. These 3 things I avoid bladder injuries.
In general, when you do a hysterectomy, what type of bladder dissection do you do? Do you do the central technique or follow the lateral window technique? Both of you
Usually
can
I
give
do
me your opinions.
Usually I do central technique, but today when Sumana madam was explaining, I felt okay, lateral technique appears easier. Generally, I do central technique.
Central technique. Even in cases
Actually,
of previous to LSA?
Yes, ma'am.
Sure. The other panelists, can you please give your thoughts
usually
on
I
it?
do lateral technique, ma'am, because my surgeon taught me like that. So I feel comfortable with the lateral techniques.
Can you explain how
So
will
can you please tell us the advantages of the lateral technique and the anatomy of that area, and why do you feel that's more safer?
Ma'am, going through laterally means that the chance of bladder injury might be very, very less, I feel so. The area of separation is much more easier while compared to the central technique, ma'am.
That's an area which is relatively free of adhesions, just above the uterine, which is where you can create a window and then get into the space between the bladder and the uterine, the lower uterine segment. Okay. So what energy source do you use, or do you use a sharp dissection for the bladder?
Ma'am, actually, we use blunt dissection.
Okay. So you follow the lateral window. You go create area between the bladder
With the
and
rest
the uterus.
vascularity and
And then how do you separate the bladder and push it down? Blunt dissection you do, but you will need something to cut, no? The UV fold area and push it down. Do you do it with scissors or use an energy source? If it's an energy source, what energy source do you use? And what
ma'am,
would you
either a
recommend?
bipolar or a vessel sealer we use.
Use a vessel sealer. The other panelists?
So
For the
bipolar.
central technique, do you use?
To start with, I started with bipolar. Then if I feel the adhesion is
Okay.
more, I use sharp scissors to dissect it down.
See,
First, I start with bipolar. If I feel it is more adherent, then I start using scissors.
Access to a harmonic keeps it more safer. But if when you don't have an access to a harmonic, I think any energy source, knowing the advantages and the disadvantages and thermal spread of each energy source will make us do the journey safe. So you need to keep in mind the lateral spread of the instrument when you dissect it, and always be very careful to cauterize more on the uterine side rather than the bladder side, and be very careful to do it only into the area where you have dissected and separated the bladder from the uterus. Sometimes sharp dissection works better, because even if you end up injuring, you recognize it on table, unless in the other case where even if you have injured, you may not identify it on table. You will end up with a leak 6 days after, when you have discharged the patient, and then you'll have to cut across a sorry figure. That's another disadvantage when you're using these energy sources. Sometimes inadvertently there could be leaks and injuries. So if you're not very sure of the structure that you're going to cut, it's better to do a sharp dissection. Or if you can have access to a harmonic scalpel, that makes the procedure more safer for the patient. So now can we just have a quick look at the techniques of bladder dissection?
Yeah, one more thing is when you have a lot of oozing, especially when you're doing a bladder dissection, you don't have to go and bipolar all of them, because most of the time it will be just a little bit of the vascularization that has happened post the cesarean section and all that. So leave it for some time. Most of these bleeding will stop by itself. And do any of you use vaginal manipulators, and do you feel that aids in bladder dissection, or do you not use vaginal manipulators and do the bladder dissection?
No, I don't use vaginal manipulators.
You don't use. So what do you normally do to, contain the pneumo?
We
So you
just
use
separate.
spiral is what you're saying, right?
Yes, ma'am.
Okay.
I use
No,
uterine
after the wall,
elevator. Sorry.
no, after
So
the
I
vault is
generally,
open, how do
yeah?
you contain the pneumo is her question. After the vault is open, how are you going to contain the pneumo? Where the gas is going to
I'll just pack it
leaking.
with a glove, ma'am.
So
Yeah.
most of my procedures are LAVH, ma'am.
Okay.
Fine.
So I generally use uterine elevators, and in cases where I feel lot of adhesions, I use myoma screws.
Elevator means you're talking about
That long instrument, uterine elevator instrument is there. That I use for elevating the uterus when I start with the procedure. When I reach the level of bladder, if I feel there is a difficulty, like there is sometimes we feel kinking in previous cesarean sections, that time instead of elevation, I remove that and put myomuscular and pull it up.
Okay.
You're talking about the sunk pulse manipulator, basically, which doesn't have a colpotomizer. It just keeps manipulating, right?
It's a long long metal instrument with two hands. I mean, it's
With
know the
two
name
prongs.
exactly.
So as
Yeah,
you
ma'am.
go in, it opens up and you can just do anteversion,
Exactly.
retroversion, and lateral
Yes,
flexion.
same
Okay.
thing.
So it doesn't have a colpotomizer for you to delineate the vaginal fornix and to stop or occlude the pneumoleak.
Yes, ma'am.
Actually, these are bladder injuries.
Okay.
So, Vanita, if you want to say anything about the bladder dissection technique.
Yeah, I think central dissection can be done in simple cases very easily. You need to know both the central dissection and the lateral window technique. So in simple cases, once you master the lateral window technique, even you have a case of previous 2 or 3 LSEs also, that becomes more safer. So learn the anatomic space and try to enter it. Always remember this dictum, yellow color, fat belongs to the bladder. So you need to keep that in mind when you do the dissection. So as I said, I generally use only a scissor, even though there's a bit of oozing here and there. There's maybe a little venous ooze, but I feel I'm very safe because an injury is detected on table. Sometimes, the lateral window also doesn't help when its bladder is very densely adherent. So those are times when you'll have to really take a risk, do a sharp dissection by just doing the central technique of pulling up the bladder in the center and then doing the UV fold first, pushing the UV fold, and then doing a layer by layer dissection of the bladder will help you push the bladder down. This is the way you'll have to go. Or sometimes you can go laterally from the left side of the patient, right side of the patient. When you've hooked up most of it, cut the central portion and push it down. These are ways by which you could do it. Many times it works, but there are some times when it may misfire and you may end up with an injury. So now, if you have not been able to do it and you feel that there's an injury, how do you think you're going to handle it on table, and how do you first identify it on table? Can I hear it from the panelists? See, now we see something there
Yes, ma'am.
on the video. Can you? Yeah.
Yes, ma'am.
Yeah.
Able to identify the rent. Once we identify the rent, sometimes I feel it is better to suture it earlier than before removing the uterus than to wait till the end. Because after removing the uterus, it becomes very difficult to suture the rent. First,
The
finish off
first
the
thing
rent
is we
closure
need to
and then.
The first thing, we need to identify the site of the injury, whether it is in the anterior wall, fundus, or it's in the trigone of the area, whether the ureters are involved. All these are factors which we'll have to look into it. If the trigone and the ureteric area is involved, straight away we'll have to involve a urologist because stenting of the ureter comes into play. So most of the time it's the dome or the fundus which is the problem where we really hit and we don't go to the posterior segment. So once you identify, then comes the separation of both the layers. You have to dissect the anterior wall of the bladder and then dissect the posterior wall of the bladder. And then what suture do you use and how many layer closure do you do, doctor?
As we do like C-section, ma'am, it is a double layer closure of the uterus using the same vicryl.
No, you should use a 3-0 vicryl. You could do a 2-layer closure. First layer could be intermittent and the second layer could be a burying limber, like a continuous suture. But 3-0 vicryl is a material which is used. People do use PDS now, but urologists are wary of, they don't not approve using V-lock or any barb suture because they feel it it promotes the formation of sludge and stones, so they don't like using a V-lock. But for easy suturing techniques, there are still surgeons who use. So if you have identified the rent, now you have sutured it. Now what is that you're going to tell the patient? How long are you going to leave the catheter, and what are the precautions we need to do now?
The continuous bladder
We have
drainage is
sutured the
very
rent. We have sutured the rent. So how are you going to check for the intactness? What catheter do you leave, and how long do you leave?
So Foley's, once after suturing, at the end, we always do I use the hysteroscope to just look into the, I don't have a separate cystoscope, so I use the hysteroscope foramen to look into the uterus and look into the bladder. Then once I feel it is intact, then I advise continuous bladder drainage at least for minimum of 14 days with Foley's in situ. I send the patient home, but with Foley's.
Yeah. A cystoscopy at the end of it sometimes may disturb your suturing also, but I would generally prefer a cystoscopy where you suspect a thermal injuries to look at how much damage you've done to the mucosa, so that if there is a mucosal whitening or charring there, then you can underrun the area with a suture. But after you've identified a clean cut injury like this and you've sutured, a simple methylene blue to check, the intactness of the bladder is more than enough. Oh, would the other panelists agree, or the
Yes, ma'am.
my moderator has anything to add on?
Hello.
Meena?
Hello.
Yeah. Yeah.
Yeah. So I think a couple of things that she was saying, that in terms of wanting to suture the rent at the end of the procedure or the beginning of the procedure. One thing is, it is preferable at the end because you will know where all you have made injuries, so it is easier that way. And second thing is, if you finish the procedure, actually the uterus does not come in the way, so you can mobilize the bladder well. You will get a better exposure. Uh, so I think if you have a continuous drainage, like if you have the Foley's in place, you will not have much soiling even when you have to wait till the end of your procedure and then do it. So I generally prefer to do the suturing at the end of the procedures, have more space to suture it well. And as far as cystoscopy is concerned, I don't think you should be doing a cystoscopy post a repair. Like Vanita said, if you suspect a bladder injury, or if you think that you've used too much diathermy on the bladder surface, then you can go and see cystoscopically if there is any blanching areas. So if there is a suspected area, then you can possibly, reinforce that laparoscopically. But once you have sutured, just a distension simply with methylene blue is enough to just see if your suture line is water intact, or, it is not leaking. That is sufficient, because sometimes when you put in, under high pressure, you can compromise on the suture. So a simple distension of the bladder to just make sure that it is watertight should be sufficient. Yeah, and suture material, I think 3-0 is what is ideal, but sometimes we use 3-0 barb sutures also to suture the bladder end. Keep the catheter in for 2 weeks, I think you should be okay.
The most important thing is to leave a wide bore catheter, at least a 18 French, and a 3-way catheter, silicone catheter is preferred.
And intra-abdominal drain I place in all such cases.
That is also sometimes, if you will know that initially there is any leak, you'll be able to identify with the intra-abdominal drain. The second,
The surgeons always like to leave a omental patch there. So if you are wanting to do that over the site of repair, you could leave a omental patch also.
yeah, I prefer generally for a fistula repair more than for a primary bladder injury. Because most of the time, if it's a fresh injury, it will heal well if you just keep the catheter in place. But if you're doing a leave repair, then definitely keep an omental patch, especially between the vagina and the bladder area.
Whenever I injure a bladder, I always hear Raju Maheshwari's ma'am's voice linger in my ears. Bladder is very forgiving. You just have to approximate and leave a catheter. It heals up well. This is something which I heard when I was a second year postgraduate, and still I keep rehearing that voice in my ear.
So sometimes you can have a superficial bladder injury also. I mean, in this case, we tried saving the bowel, but ended up cutting the bladder. If you identify the bladder injury, it is important that you inflate and see after all your previous sections, put methylene blue and check. Whether cystoscopy is routinely advised after all hysterectomies is debatable, but at least you can fill the bladder in suspected cases, so that even if the serosa is breached and the mucosa is intact, you're still okay. You can leave the catheter for some more time, or just take a reinforcing suture on the serosa.
The best way is when your catheter is inside and you've connected it to a euro back, the bladder tends to bloat like a balloon. So that will tell you have injured. The other thing is immediately you will be seeing bloodstained urine there. These are things which we cannot miss at any point of time.
So these are the things, principles of bladder repair. Best to identify it intraoperatively, inject methylene blue to see it, continuous drainage with Foley's, close in 2 layers, including the mucosa, and absorbable sutures to be used. Leave the catheter for 14 days. I think we will move on to the ureter. So these are all some of the tips for bladder dissection, lateral window approach. I think we've gone through all this. So coming to ureters, so I think a bladder at least is little more forgiving and easier to repair. Coming to ureters, what are all the measures that you will take, especially in cases of endometriosis, to prevent the ureter from damaging? This should be a case in all surgeries, identifying the ureter at the beginning of the surgery and know where the position is very important, especially before you start opening up any planes. If you see, you can identify the ureter. The best place to start detecting the ureter is as it is entering the pelvic brim, at the point where the ureter enters the pelvic brim. If you identify it there initially at the beginning of every surgery, it is easier that later, if you want to trace the ureter, it is easier. So, do any of you stent the ureters preoperatively in cases of endometriosis or patients with large fibroids?
Yes, ma'am. If it in huge fibroids and severe endometriosis, we usually stent.
Routinely or when there is hydroureteronephrosis?
Routinely in huge fibroids and severe endometriosis suspected in investigations, then we stent it.
So you stent it preoperatively or on table?
Preoperatively, we send to urologist, they stent and come, then we take up the case.
Okay.
Okay.
What about Dr. Vidya? Dr. Vidya, who is the other person with us?
Dr. Dharni, ma'am.
Dr. Dharni, sorry.
Ma'am, during the large fibroid cases, I used to do stenting post-operatively. That too, if I see if there is a hydroureteronephrosis only, I used to do. Routine stenting prior to surgery, I won't be doing.
Do you call urologist for stenting?
Yes, ma'am.
Okay. So,
But actually, I have not done any cases of stenting till now.
okay. So stenting sometimes can be very handy. I think it is important that we all learn to stent the ureters, because sometimes urologists may not be, really available when you're finishing the surgery and you're little in doubt whether you have been very close to the ureter and you want to just leave a stent. Because most of the time, even if there is a small avascular necrosis, if you leave a stent in place post-operatively, it can help. Now, as far as preoperative stenting is concerned, it is always debatable. I don't prefer stenting because preoperative stenting can make the ureters taut and more susceptible to injury. But in case you have hydronephrosis already proven and you want to leave a stent in place, it is fine. But generally, doing it preoperatively can make the ureter stiff. Now, post-operatively, at the end of your surgery, if you think that you have been very close to the ureter, you have any suspicion that you might have used a lot of diathermy around the course of the ureter, then you can stent the ureter. Stenting the ureter is almost like similar to how you do your tubal cannulation. You just have to identify till what level you need to go. So it is good to learn stenting so that you will be able to do it intraoperatively at the end of the procedure. You can leave the stents and maybe send them to the urologist to remove the stent even as an OP procedure later. So it is good that all gynecologists learn to stent the ureters at the end of the procedure. So you can stent it at the end of the procedure. Now, in case you have a suspicion of a ureteric injury, how do you detect it intraoperatively? So just looking at the peristalsis won't really help. Cystoscopically, you can see the jet stream coming out. What we normally do is I put an MVI. MVI comes out as a yellow color, jet stream. So that clearly helps in identification whether you're having a stream of urine, whether you have transected the ureter. If you have transected the ureter, the jet won't come. But if there is only a partial wound, it will still come, right? So, but it still helps that at the end of the procedures, in these cases, cystoscopy definitely when you do. So when I start suturing the vault itself, I tell my anesthetist, give the MVI. The MVI takes about 10 minutes to come into the circulation and come into the urine. So you do a cystoscopy at that time, you can see the yellow jets from both sides. You can clearly identify whether you've not transected the ureter. Otherwise, if there is a suspicion that you have been very close to the ureter, a good idea is you can put in a stent post-operatively, leave the stent for 6 weeks and ask the urologist to remove it later. If you identify a ureteric injury, the best time is you can call the urologist and get it repaired then and there. Most of the time, our injuries are lower down, closer to the vault, or in those cases, especially endometriosis and all that, you may have to do a ureteroneocystostomy, like reimplanted the bladder.
Actually, I had a ureteric injury case, and my hospital is in a periphery. It is not in the city. So the patient complains of hypochondrial pain in the post-operative period, and we came to know that the patient had a ureteric, which was a cautery injury. We had cauterized the ureter. So from that time, on the post-op day 1, I used to do a routine ultrasound, and I'll make sure there is no hydroureteronephrosis in the patient. It became a routine thing.
Yeah, this can set in a little
Just very shy is what we hear, and it's like every time you're shy now.
Ma'am, I have a doubt. Why not if we can avoid pre-operative stenting, will definitely help. Why should not we do a pre-operative stenting routinely? Because it is something like preventing the injury which is going to happen.
About preoperative stenting, most of the time is when you stent the ureter becomes very stiff, right?
It's very rigid and doesn't fall off so easily.
Doesn't move away. So as you dissect the bladder, then ureter actually normally falls off by itself. But when you stent it and taut, then it doesn't easily fall off, and the chances of injury is more. That is why it is not. That is why lighted stents came in, where at least visually you can see the ureter. That also is not going to help, because the same tautness will be there, but at least visually you know where the ureter is and whether you're dissecting far away from the ureter. So that is how lighted stents might help. But routine preoperative stenting is not proven to be of great benefit to prevent ureteric injury. That's what I meant.
At the end of the day, you would say more than preoperative stenting. When in doubt, intraoperatively, you please stent it.
Intraoperatively, you should be ready to stent it. And always in such cases, when you have a lot of endometriosis, obliterated POD and all, you start with the ureterolysis, identify the ureter, open the lateral pelvic wall, and you know where the ureter is, rather than trying to find it at the end of the surgery. This is what I feel helps, because at the end of the surgery, it can be difficult to find the ureter. When you're starting the surgery, when your planes are a little more clean and it is not very messy, start identifying the ureter right from the place where it crosses the pelvic brim. So there you identify, that's the best place to identify the ureter. It's one of the standard anatomy. After that only, we don't know where it is going, closer to the structures we're going to be looking at. So open the lateral pelvic spaces, identify the ureters, look at the peristalsis. So you will have an idea whether it is very close to the IP, or whether it is lower down, or whether it is pulled up to your endometriotic nodule. These things you can identify. Then you come, after you complete the procedure, it is more easier to identify the ureter's course. So ureterolysis has to be done in difficult cases when you have a lot of obliteration of the POD or endometriosis. And stenting, like I said, at the end of the surgery, if you have a suspicion, stent the ureters. I think the last part is quickly we will go through bowel injuries and then wind this panel. Vanita?
Yeah.
Small bowel.
Yeah, bowel injuries again can be at entry or during dissection, especially when you have adhesions, and not to mention also the energy source related. And there you can see up a video coming. I'm sure it's a post-op video where you can see a little fluid collection there. What is that you suspect when you see something like this? Postoperatively, patient is coming to you with distension, pulse rate is high, and fever, and then you go in for a relook and you see this sort of collection.
Actually, this
For
was
sure, you know,
this
Looks
was
like urine.
this was
this was like a
Looks
Bladder
like a
injury.
bladder or ureter injury. You
Bladder
more of
injury.
urine.
No, this was like a TB abdomen. There were a lot of tubercles and fluid. The reason why I put it is there were most of the time in TB abdomen, you have a lot of small bowel adherent to the anterior abdominal wall. So entry, while you enter itself, you can go through and through into a small bowel. So when you're putting in, the second report, you must ensure, especially in abdomen cases like this, you have to look at all the port sites. You change the camera to another port site and ensure that wherever you have entered without visualization, if you've not entered through a bowel loop through and through, especially when you have a plastered abdominal wall. And in small bowel injury, the most important thing you have to identify is the entry point as well as the exit point of the trocar. Many a times you will only see one point and suture it, but there will be an exit point also for the trocar which needs to be identified and sutured. Because the small bowel has got a very small and thinner lumen, so you may go through and through when you're doing a potential. So you have to identify the exit point also of the small bowel. This is what I was telling at the beginning also. When you go in multiple times, especially when a difficult entry is there, if you have hit the small bowel or not, if you are in doubt, the other thing you can always do is post-operatively do a CT contrast and ensure that there is no leak.
So what are the precautions that you will take when you have a patient with previous, bowel surgeries or a previous pediatric age group bowel surgeries, and you find weird scars all over the abdomen, more so in the upper abdomen? How would you prepare this patient preoperatively, and on table, what are the precautions that you will take to avoid a injury?
Bowel preparation. Previous day, liquid diet on the day of surgery. Previous day of surgery, liquid diet and nil per oral from night. And
would you give an enema, or do you go ahead with peg leg, Exelite, some lactulose? What sort of proctoglycos? What sort of enema do you give?
We generally give peg-leg here.
Okay, for all.
For complex surgeries.
Okay.
Otherwise, we just give enema. For other routine hysterectomies, we give just enema.
Okay. And how do you enter in such cases when there are multiple?
It is always Palmer's
previous...
point and 5 mm. 5 mm and Palmer's point.
So you identify from the Palmer's point, and then you choose the trocar telescope site, and which is free of adhesions, right? So
yes,
after having taken all the precautions also, if you end up with an injury like this on the small bowel, how do you repair it?
It's usually called
call a general surgeon. And one thing all of us need to do is really gain a prowess in suturing, so that we will be able to suture the bowel. For medical legal purposes, we definitely need a surgeon to be with us to handle the issues, but we can always do a double layer suturing if it's a small bowel. Large bowel, yes, maybe we should have a GI surgeon with us. So even if you're not very confident of doing a laparoscopic surgeon, all that we can do is do a very small mini laparotomy by extending one of the ports, loop this segment of the intestine which has been injured through that extension, suture it open, and by the open technique, and then push it in. That is also something which you can do.
And also,
again, the same suture material, 30 vicryl can be used. A 2-layer closure can be done. And I think this is the purpose of attending suturing classes that we conduct at TOXI and IAG, because we'll help you become masters in suturing.
Yeah, and always leave a drain. I think for bowel injuries, it's better always leave a drain till the patient passes stools, because that's the earliest thing you can detect. Even if there is some leak post-operatively, you'll be able to detect. So leave in a drain, that will help. So this is sometimes you can have a trocar entry directly into the large bowel. So this is one instance where we found that we put in the trocar, it was straight into the lumen of the transverse colon. In this particular case, we just, opened, looked at the site, and then went ahead and closed it. But yes, if you are able to detect and you have the facility for having a surgeon around, or if you can suture it intraoperatively, it is best to suture primarily all the bowel injuries. If you have a good, well-prepared bowel, I think most of the bowel injuries, if you intraoperatively primarily suture it, there is no problem. When you have a bowel injury, main thing is just don't take that trocar out, because you will lose the site of injury. Keep it, put in another trocar from another side, see where it is, hold that point, and then you proceed however you want, whether you want to go laparoscopically, open, whatever. But, otherwise you will be hunting for the injury. So if you have entered through a particular trocar site, just leave that trocar, go to another site, put a new trocar, see where this trocar has entered so that you don't miss the injury. Right. Anything else you want to tell about bowel, Manita?
Very judicious use of energy sources on adhesiolysis is very, very important, because a bowel leak post-operatively can sometimes, very small leaks can be missed early and can be picked up late. So very judicious use of energy sources is something which we'll have to practice. And any patient post-operatively always having tachycardia with distension, bells should ring, and we should always think about it. And any patient, I would say, not recovering in the usual form that a routine laparoscopy patient does, and when you know that you've had difficulty during the surgery, please be more vigilant, is what I would always tell.
Yeah, post-operative pain, fever, tachy, bleeding, bowel injury, I think we definitely need to, be doubly sure that it is not there.
We must always have the thought and be vigilant to pick that up.
They come back after a week with abdominal pain. Sometimes, even diagnostic laparoscopy.
These injuries and all very small injuries, or a very small pinpoint lesion which you would have just caught in a diathermy and then it would have sloughed off after 5th day, 6th day. These things do happen when we go in with a relook laparoscope, identified, it's just like giving a wash to take off all the flakes, and then you'll have to just start using that suction irrigation just to see where the mucosa is propped up, and then clean that area, freshen the edges, and then do a 2-layer closure. Depending on the site, whether it's a small bowel or the large bowel, we need large bowel generally presents more, in a more earlier, and in a more, it'll be more dramatic in the large bowel. Most of the times, 1 week is small bowel only. So maybe it is the surgeon's decision to do whether they need to do ostomy. But most of the time, small injuries do heal with this, and leaving a drain is most important. Stepping up the antibiotic, and sometimes these patients need a multidisciplinary approach. You need to talk to the physician, because a week's time would have also taken the other things like infection, other things also needs to be handled.
When in doubt, always leave a drain, and post-operatively we keep a pulse oximeter at least for 24-48 hours. So we ensure that, one of the few early signs is fall in saturation, tachycardia. These don't ever ignore, especially when you have a difficult adhesiolysis, bowel adhesions and all that. I mean, it can happen to anybody, but picking them up early and then treating them is what will be very important. And you can also, we sometimes counsel the patients that there were a lot of bowel adhesions. We have done a lot of adhesiolysis. We will keep for observation. In case there is a leak, we will have to close the bowel. So you can tell them and keep, and then, they will also be vigilant. Sometimes attenders send me a pulse oximeter findings in the night saying that, everything is going okay.
Very elaborate.
Attenders are more vigilant than our nurses at times. When you told them, when you clearly explain them, what are the parameters that they'll have to look for, they look for it better.
Even in labor, birth companions are better. You can ask them to monitor the CT. If the heart rate goes down, you just come and tell, or if anything else, so they'll be by the side. So the same way, I think they are better if we give them the right knowledge.
Yeah.
Thank you so much.
Learn from others' mistakes.
Pardon, ma'am?
Learn from others' mistakes. When you come across somebody telling you about a complication they've had, we should always know what led to the complication, how they identified it, how they tackled it. So whenever we land up in a situation like that, we should never get into it. We should try to safeguard ourselves and our patients.
Yeah, yeah. Yeah, in the UK, I've seen one where they injured the aorta, and then luckily the vascular surgeon was there, so he came and helped the consultant. But the consultant fainted immediately. But it was like a day unit, so they didn't have blood also. But the ambulance had to be brought, and they gave like 14 units of blood and transferred her to the other higher center which was close by. Luckily, the patient was saved. Anyway, so these things do happen. And also another patient, because there it's all daycare procedures like, in diagnostic laparoscopies, and one of them came back after a week to casualty. So only if we know these complications, just whatever you said, you will be able to identify. Otherwise, okay, a pain, nothing much. Sometimes it's just localized pain. And if we don't treat them with antibiotics or, admit them, best thing is to admit any post-op patient. When they come back with, with a pain or any complication.
The important thing is never ignore any post-operative complaint.
Absolutely, yes.
Patient is the bed.
Is more important. Yes. Thank you so much, ma'am. Thank you, both of you.
Thank you, panelists.
Great and interesting. I think we should.
Thank you, ma'am.
Thank you, panelists.
Thank you, ma'am. Thank you.
Radhika ma'am, quiz results are out, ma.
Yeah, okay. Please. So for the first question, Dr. Danya Shanmugam, congratulations. So the answer is the Commerce Point. She's from Dindigul. And Dr. Gauri Manohari wins the prize for the second question. Thank you so much. And congratulations to the winners. Thank you, madam. We'll wind up the session. I thank the president of TNFOG and secretary, Dr. Sampath ma'am, Dr. Vidya Prabhakar ma'am, who is the president, and also all the delegates who and the faculties who've been present here and given wonderful lecture, as well as a great panel discussion, with even minute points and best videos we could ever see. Even in conferences, we will not be able to have such a close look. Thank you so much. And the speakers, Dr. Siraj and Dr. Belinda, thank you. It was very good presentation, both on hysteroscopy and laparoscopy. Thank you and for the IT support, Mrs. Priya and Mrs. Sahiti. Thank you so much for all the help. Thank you. Sahiti? Sahiti?